welcome to another episode of Idioms of Normality. I'm here with medical doctor and philosopher, Dr Yves Saint James. Yves, thank you very much for joining us.
You're very welcome, and thank you for giving me this opportunity to talk about your subject on normality.
And before I lead in with the first question, I like to ask people, what perspectives and experiences do you bring to the question, what is normal?
It's a really good research interest for me because in my doctoral thesis, I looked at the intersection of health, beauty, and normality.
Health, beauty, and normality. Oh, great. Oh, well, we're going to delve into all of that.
Yes.
What is normal?
That's a really difficult question. And it took me about 3 years to finish my thesis, and I don't think I have an exact answer. But just a little bit of a background, my doctoral thesis looked at the ethics of pathologizing ugliness, or treating ugliness as if it's a disease that requires medical intervention.
Wow. So pathologizing ugliness and intervening on what people perceive as deformities or blemishes.
Exactly.
What kind of deformities, what kind of blemishes are we talking about?
This is also a difficult question, so we have to step back a little. When it comes to pathologizing ugliness, I'm referring to features that are just deemed to be undesirable based on some aesthetic standards. So these are different from deformities that can be medically and surgically defined. So these are just maybe the nose is a little bit too big, or the nasal bridge is a little bit too flat, or the eyes are too far apart. There's no pathology there. It's just that some people don't find them attractive. And what's happening in cosmetic surgery is to start framing these normal, so let's put it in scare quotes, but unattractive features as if they are pathological. So they start using medical language to label these terms. And there you have to ask, what is normal then? If there are features that are unattractive but normal, and it becomes pathologized, it does raise the question, how does medicine define normality? How does cosmetic surgery define normality? And that's one of the things I look at. I spent a few chapters looking at the term normality. And there I found there's two general understandings of normality that's being sort of used in medicine. So you have one that refers to normality as statistical.
Right.
So it's what we refer to as frequentist approach to normality. If you know the bell curve, anything that falls under the bell would be normal. And those who are in the extremes are either below normal or above normal or abnormal. In a medical sense, abnormal is not necessarily moralistic. It just means it's not normal.
Right.
That's the first one. The second one is the normative notion of normality. So it's the thing we want to achieve. It's very aspirational or ideal. For example, you have conditions that you will treat as abnormal or pathological, but it's fairly common. So think of any kind of disease that's widespread. Think of COVID or any kind of infectious outbreak. They are statistically normal, but they're not desirable. We don't want to have COVID-19. Mm-hmm. Another example would be tooth decay. It's a very common condition, but it's something that we do not want. So there you can see the conflict between the statistical normality and the normative normality. And there, it becomes more complicated if we start talking about beauty and health.
Right. So as a starting point, when we're talking about normal in the statistical sense, tooth decay might be normal.
Yes. Statistically. Yeah.
But normatively, tooth decay is undesirable.
Yeah. And therefore not normal.
And what your research was looking at is how this notion of undesirable has drifted into physical traits that are benign. So the shape of certain facial features, for example, there's no biological consequence to that shape that impedes physiological function. But people are finding them undesirable, and cosmetic surgeons in sort of this feedback loop are pathologizing it.
One of the terms that we use, feedback loop, is very important here. That's why it's very difficult to disentangle these notions of statistical normality and normative normality, is because they feed back onto each other. One way to explain this is there is a lot of trends and evidence in the history of, cultural history, where the normal was idealized and the ideal was normalized. And these are two different processes that I looked at: the normalization of normative and the normativization of normality. These are big processes, very complicated, and it's something that I had to disentangle. So let's look at the first process, the normativization of normality. So it's when you're converting a statistically normal thing into something that's ideal. It doesn't have to be supported by any biological benefit. It's just a thing. For example, having 10 fingers. Having 10 fingers is a statistical normality, but at the same time, it's also normatively ideal. But we've reached a point where this having 10 fingers is so normal that anything that deviates from having 10 fingers is considered to be undesirable. And if that happens, we have to intervene. So polydactyly, that's when you have an extra finger. Medicine will require, or at least recommend, that you get rid of the extra finger. So that intervention itself idealizes the statistically normal feature of being what it means to be a human being, or what a human being looks like. So surgical interventions and any kind of medical intervention that safeguards, or at least ensures, that we follow statistical normality idealizes that statistical normality.
Right.
And it becomes desirable.
Wow, and that becomes so much more complicated when you think about people who are born with both sexes, or...
So intersex is another kind of restricting statistical normality, and everyone that deviates from that statistical normality will receive intervention.
Right.
So that they're aligned with the statistical normality. And you have a lot of cultural problems that come with that. For example, albinism in Africa. So the idea that when you deviate from normality, you get punished. There's a lot of problematic assumptions, and this is something that you're probably aware of. There's a lot of presumptions when people deviate from normality. They're the works of the devil, they're possessed, or they're bad omens. So that's another way of cultural strategies and ensuring that the statistical normality becomes the ideal, and any kind of deviation has to be corrected.
Right. And can the inverse happen as well?
Yes.
Can it be exoticized? And
so the inverse process, or I call it the twin process, because they do go hand in hand in this feedback loop. It's when you normalize the ideal. So usually you have ideal features that don't really exist by themselves. They usually exist by a lot of effort, or like usually by surgical intervention. So one example would be bodybuilding. Unless you do manual labor, you will get a very muscular body. But a lot of people will have to go to the gym, do a lot of exercise to build that muscular body. So this is something that a lot of people find to be ideal, probably because of advertisement, probably because of celebrities. And you have a lot of Marvel, superhero movies, and people see the transition between, what the dad bod looked like before, and then, this actor got the role and became muscular. And they're, this person became more beautiful or something. So a lot of sources of information to idealize a certain body type that does not exist statistically in a normal sense. But because they are idealized, a lot of people start following them. You then have this trend of people going to the gym, and then it starts spreading.
Right.
So a lot of people become muscular. So that's when the ideal becomes normalized. And it happens with in the fashion industry as well. The waif look, being size 0.
Oh, okay.
So being thin, for some people, you have to make an effort to stay thin. For other people, because of metabolism, are naturally thin. But there was a time in the fashion industry where size 0 was the thing, was the ideal, even if it was not statistically normal.
Yeah.
But when people found it to become desirable, all of a sudden everyone's size 0, at least for women.
Right.
So that's when the ideal, because of some cultural or perhaps medical trend, they start aligning themselves to that ideal standard, and it becomes normal.
And we see the effects of the impact of that on wider society, don't we?
Yes, definitely.
What are some of the spin out, or the rollout, or the effects, or the spillover into wider society?
A lot, definitely. Oh my God, like where do we begin? That's something that you might want to explore with your other speakers, but I'd like to speak about medicine in particular.
Okay.
So definitely in surgery, there is a increasing collapse of the distinction between plastic surgery and cosmetic surgery. And just to explain, plastic surgery or reconstructive surgery, it consists of interventions for features that are pathological. So it usually involves deformities caused by injury,
Right.
like vehicular accidents or burn injury. It could be caused by congenital disorders or any kind of post-surgical markings of surgical interventions. So that's reconstructive surgery. Cosmetic surgery is supposed to be, it's supposed to consist of procedures for features that are free from disease, deformity, or pathology caused by injury or congenital disorders.
So there is actually a distinction between cosmetic and
It's a
plastic.
blurred distinction because then you have to say, what does it mean for a feature to be disease-free? What does it mean for a feature to be normal? So reconstructive surgery would be for features that are abnormal or pathological.
Yeah.
Cosmetic surgery would be for normal but undesirable features. So then you do have to ask, like, what does it mean for a feature to be normal then?
And does that also problematize what is disease?
Yeah, definitely. And there's this huge debate of what disease is in philosophy of medicine.
Yep.
Not so much in medicine, because medicine is broken up into different specialties, and each specialty would have their own definition of what counts as disease. But in philosophy of medicine, you have this sort of parallel debate. What is a disease? Is disease something that's statistically defined? So it's the frequentist approach. Or is it something that's normatively defined, in the sense that we look at disease not because they're statistically infrequent, but because they are just undesirable.
Okay. So, I mean, you've got the notion of disease in terms of infectious disease. And even there, I think there's a difficulty in defining it, because not everyone who becomes infected necessarily becomes sick.
Yes.
And then you've got the notion of disease as in mental disease,
Yes.
Mental illness. And within the categories of mental illness, you also have difficulties defining the exact pathology if it is pathological. And then here you're talking about our physical features, our beauty, and how beauty can be pathologized. Is the word disease used by medical doctors? How are
they would use terms like deformity. So there's this nice terminological invention that a lot of cosmetic surgeons are now using. It's called aesthetic pathology. So aesthetic pathology is just another way of saying ugly. And they're trying to make a distinction between functional pathology and aesthetic pathology. So functional, let's use the example of nasal bridge, or this part of the nose.
Okay.
A functional pathology is anything that might obstruct respiration. So it might cause difficulty of breathing.
Okay.
So if you have injury on the nose, if there's broken part of the nasal bridge that can obstruct breathing, then they'll call that functional pathology.
Okay.
But in the absence of functional pathology, there's just a bit of deviation or something that's undesirable, but probably a bump that's too prominent that catches people's attention. They will call that aesthetic pathology.
Right.
So they wouldn't call it disease, but they will call it aesthetically pathological.
What is the definition of aesthetic pathology? Because pathology means something causes harm, and
that's debatable. Yeah.
Oh, okay.
Yeah.
What does pathology mean then? What do we like?
Nobody knows.
Right. Okay.
That's what I was saying. Because you have a lot of definitions in philosophy of medicine regarding accounts of disease. So pathology can be something that's infrequent.
Yeah.
Or pathology is something that's undesirable because it's harmful.
Yeah.
The reason why I said it's debatable when you said something that causes harm, not a lot of diseases will cause harm.
Okay.
So you have early stages, for example, of cancer that will still not cause harm. It will inevitably cause harm, but not at the moment. And you also have asymptomatic patients. Usually there's no harm yet, or at least for that specific patient, there's no harm. So if you want to be more elaborate about the definition of disease, you have to start taking into account time. Like, when should the harm happen? Should it be happening now, or should it be happening in the future?
Right.
You have to take into account probability. If it's going to happen in the future, how likely will the harm occur?
Yeah.
And then what level of harm? Is it something that's debilitating or something that's just inconvenient?
Right.
So then all these spectrum of criteria, and we're just talking about harm. That's just one tiny criteria, one of the tiny criteria that people talk about definitions of disease.
You're making me reflect upon something my parents did for me or to me as a 5 or 6 year old. I went into hospital and they had my ears pinned back. So I used to have very big ears, and I think I inherited them from one of my parents.
Yeah.
No naming names.
Yeah.
And I'll never know really after that time what it is like to have big ears, because I never grew up after the age of 5 or 6 with big ears. But my parents chose to do that apparently because they saw that as a potential feature that could be picked upon.
Yeah.
And so they felt, okay, to avoid that distraction in our child's life, we're going to pin his ears back. And they convinced me of it. And I went to hospital kicking and screaming because I was getting carried away by the surgeon who did the operation. And, to be honest, it's been quite a fairly benign experience for me because I just wouldn't know. But is that the kind of time trajectory you're talking about? Like someone sees an aesthetic pathology, big ears as an aesthetic pathology, and someone foreshadows, well, I don't want people being distracted by the bump on my nose, my big ears, or my eyebrows, or my eyelash, I don't know, and foresees that this could be a distraction socially, and they can address the social problem by performing surgery on the biological.
That's a good example, and it demonstrates the complication of the harm that we talk about when it comes to disease. Because then you also have to understand what kind of harm are we talking about. Is it physical harm, where the body of the person involved is the one that's being harmed? Or is it social harm? So social harm, there's nothing wrong with the body. There's no physical interaction. There's nothing wrong on the cellular level. But it's the response of the society towards that feature. It's the harm that comes with the response. Stigma, bullying, perhaps marginalization or discrimination, outright discrimination.
Or possibly even affecting social mobility?
Social mobility. This is the problem that a lot of medical sociologists look at when it comes to the phenomenon of medicalization and pathologization, which refers to what happens when we turn a social problem into a medical problem.
Okay.
Because then you have to ask, whose burden is it to carry or to resolve this? Is it the burden of the medical profession to correct features that are normal? I should not have used the term correct as well. To modify features that are normal but are undesirable? Or is it the society's responsibility to just challenge any kind of oppressive standards of normality?
Right, yeah.
So to answer your question about the example of the ears, yes, it demonstrates that some people, even with good, well-meaning intentions, can be patronizing about what it means to be normal, and they want to protect individuals from bullying. But you have to ask how much complicit these people are in maintaining standards of normality that causes the oppression in the first place. And that's the question I raised about medical and surgical interventions that uphold this notion of normality that has implications about bullying, about social harms, and about marginalization. Even if the intention is to prevent people from being bullied, you're being complicit to that culture of bullying because you are maintaining this very strict standard of normality. How far out should the ear be for it to be considered normal, or far in for it to be desirable? It's very arbitrary. Sometimes, even like if you look at measurements, because I had to go through illustrations of normal noses, normal ears, normal lips, and the proportions and stuff. A lot of the definitions of normal deviance or deviations are down to millimeters.
Wow.
You'd be surprised if it's off by 2 millimeters, for example, they would recommend intervention. So then you have to ask, it's like, is normality really defined just by a few millimeters? It's like, and then you start asking about other kinds of measurements of normality when it comes to blood pressure, when it comes to heart rate and pulse rate, and other clinical variables.
Right.
It's really interesting.
As you were talking there, I was thinking, it seems almost like we are both the producers and the products of these systems. We are both the drivers and the driven.
Yeah.
Is that what you meant earlier on about being in a feedback loop?
Yes.
Right.
So that's why it's hard to disentangle, because we don't know where it begins. And of course, social cultural history and medical history have gone so far back in time that we don't know which started it. But at the same time, so we're now in not really a loop anymore, more of a web, because we can't really trace back who started what in terms of standards of normality. But we are subscribing to and reproducing standards of normality.
What do you see as the key drivers of this feedback loop?
There's a lot, but in terms of my research, I looked at the responsibility of medicine.
Okay.
So the role of medicine and the authority of medicine in upholding standards of normality. It is to be expected, of course, because medicine is the source of a lot of biological notions of normality. That's why it's there. It's there to prevent diseases. The medicine is there to cure diseases and to help people live a better life. But at the same time, even without meaning to, medicine has been involved in upholding a lot of types of normality that's oppressive and continues to marginalize sectors of the population. And one of the things I'm still really interested in, is the history of the relationship between medicine and gender.
Mm.
So you have homosexuality, which was pathologized up until late 70s.
Right.
Just because of the frequentist notion of normality. And that fed into the moralizing of homosexuality as abnormal. And medicine's notion of, for example, procreation as the basis of biological normality is still very pervasive.
Mm.
If you cannot reproduce, you're not normal. So that's for me, medicine is playing this role, continues to play a role in a lot of problematic implications of what is normal. Whether it's in terms of standards of beauty through cosmetic surgery, whether in terms of gender, and that's across the board in medicine, and trying to intervene, and then even biological sex. So usually you have to uphold the binary of the biological male and the biological female. Anything that deviates from that binary is abnormal and has to have an intervention. So all these things, at least my interest is focused on medicine. But definitely in terms of drivers, you have cultural drivers like the film industry, TV industry, the academia that will play a role in terms of normality. When you talk about examination results,
right,
it's very statistical, it's very frequentist approach. Even the definition of intellectual quotient has a very problematic history, and that's being upheld. So a lot of students are defined based on their outputs. So all these things, and I'm sure you know a lot more other drivers, but in terms of my research interest and my expertise, I'm definitely not an expert on anything, but in terms of my background in medicine and also in philosophy of medicine, I'm really interested in the role of medicine as a driver for upholding certain types of normality or standards of normality.
The role of medicine as a driver for upholding the standards of normality. Eve, before we finish, there's so many more pathways I could drill you on, and in some ways, I've got so much to go home and reflect about. What questions should we be asking about what is normal and the values and the standards that are being upheld by medical notions of normality?
Personally, I think you have to ask, what are you using the question for? So if you're asking the question, what is normal? What is the context of the question? It's very hard to just go through the question in a general and broad sense, because it's too broad. Like normality, even the notion of normality is just way too broad. So for me, if you have to ask that question, in what context are you asking that question? Are you talking about biological normality? Are you talking about social normality? Is it in the context of medicine? Is it in the context of culture, or perhaps wider society? Because each sector and each part of the society will have a different use of the term normality. The second is, if you're asking that question, are you ready for the implication?
Right.
Because if you offer an answer, it will have consequences. And that's what happens in medicine. When medicine defines normality, it has consequences. Anything that deviates from the medical definition of normality has to be treated. There has to have an intervention. So even outside the context of medicine, even in just, talking about society in general, in the notion of normality, once you start offering answer to the question, are you ready for your own answers? It's like, are you ready for the consequences?
Yeah, because things can spiral out. And, as I think, as you've been saying, in some ways you might start by defining normality, but then if we can correct things to the normal, then shouldn't we also enhance things if we have the technology? There's so many more questions that we could be.
Yeah, definitely. When it comes to enhancement, that's another rabbit hole, because enhancement moves normality. So enhancement, once you start enhancing individuals, create a different definition of normality, and then it's catching up. So yeah.
And then we'll have another episode of enhancement.
Definitely.
Dr. Yves Saint James, thank you very much for your time, and thank you for watching another episode of Idioms of Normality.
Thank you so much.